Good evening, sir.
Good evening. અવાજ શેનો છે આટલો?
Sorry, sir.
હા, કઈ વાંધો નહીં. શેનો અવાજ છે પણ?
Sir, mobile પેલામાંથી sir redirect કર્યું.
અચ્છા, ઓકે. કર દે ચાલ.
Yes, sir. Today's topic is hematoma. We have prepared by me and Dr. Chindan, second year resident under Wednesday Surgical Unit.
ચાલ ફટાફટ ચાલુ કર.
Hematoma, it is a came from Greek word hematia, which means fault or defect, and oma means tumor or neoplasm. Hematoma is a disorganized mass made up of an abnormal mixture of cell and tissue composed of cell native to that place. Like if it is a lung hematoma, that will containing of cartilage and the smooth muscle or the mucus secreting gland, which is already present in lung. It is a developmental error only. And the second word is choristoma.
Actually, Girish, hemartoma word has come from Latin word. Missing the arrow. That was the basic concept behind hemartoma. Means when there were games were going on, the arrow which missed is known as the hemart. From that, the word hemartoma has come. So it is actually defined as a missing arrow. So the normal development is diverted at other places and actually develop into true into the true tissue. It develops into mass. That is the hematoma. Okay.
Another word is choristoma. It is a cohesive tumor-like mass consisting of normal cell in the abnormal location, which is a ectopic island of normal tissue, like in Meckel's diverticulum, which is containing gastric mucosa or acid-secreting gland. It is only heterotopia, not a tumor.
Yes, very good. So remember this word. It is a choristoma. It means that it's a pancreatic tissue in Meckel's diverticulum. Right? Similarly, ovarian tissue are found at many places. Those are the different. But there is a one different point that tumor secreting abnormal hormones is not a choristoma. Means odd cell carcinoma that will secrete so many other hormones, including thyroid hormone. So in those cases, they are not choristoma. That is a malignancy. But choristoma is a normal tissue at abnormal place. Whereas the hematoma is an abnormal tissue at any place. Okay.
Another word is teratoma. Teratoma is a tumor arising from more than one germ cell layer, usually all of 3 layers, which is a dermoid cyst of ovary, which is consist of skin, teeth, or any from other layer, mesoderm, which is from connective tissues. And
again, there is some misconception you have got. Dermoid never contain teeth. Why? Remember, the dermoid is only related to epithelium, whereas the teeth arises from mesothelium. So the ideal word which should be used is teratodermoid. The only dermoid is very rare in ovary, whereas the teratoma is arising from more than one germ cell, where the true dermoid is only one, and that is a epithelium. Ectoderm is causing that. Whereas the teratoma are multiple. Means it can be mesothelium, it can be ectothelium, it can be endothelium. You understand? So it contains cartilage tooth. Then you should call it teratoma or teratodermoid. Whereas the dermoid cyst contain hair because it is a part of ectoderm. So only thing which dermoid contain is hair. Teeth will be contained in teratoma, not true dermoid. So better word which is used is teratodermoid.
Another word is dysplasia, which is defined as cellular level. It is a loss of uniformity of the individual cell and loss of architectural orientation. It is may or may not be pre-malignant. And whether choristoma and hematoma, which is at the tissue level, not at cellular level. First hematoma is hemangioma, which is a most common hematoma among all. Hemangioma is a tumor of infancy that exhibit a rapid postnatal growth and slow regressing during the childhood. First one is infantile hemangioma, which is the most common hemangioma of all, which is expressing a GLUT1 receptor, which is usually a glucose transporter in the placental cells, and it is a best marker to identify infantile hematoma by biopsy. But there is a GLUT1 transporter may be seen in the erythroid RBCs and placental microvessels. Infantile hemangioma can be occur due to the embolized placental cell, or can be due to the immunophenotypic alteration in the primitive cells, or the somatic mutation in the single endothelial cell leading to clonal expansion, which is form the tumor-like growth. In infantile hemangioma, which is occur usually in neonate in the first 2 weeks of the life, more common in the female, which is 3 to 5 times more than male, which is most commonly solitary. 80% are solitary and 20% are multifocal. 23% in preterm infant, which is if weight is less than 1 kilogram. More common in white people than in black. It is never occur in adolescent and adult people. In congenital hemangioma, it is a rare variant that grow in utero and present completely from at the birth. Otherwise, infantile hematoma presented at the first or second week of their lives. Classification is the ISSVA classification, which divide in benign hemangiomas or benign vascular tumor, vascular lesion in the tumor and malformation. In tumor consists of hemangioma, hemangioendothelioma, and angiosarcoma, and pyogenic granuloma, and miscellaneous. While in malformation, it be a flow malformation or fast flow malformation. Slow flow malformation occur due to the capillary malformation or due to the lymphatic malformation or due to the venous malformation, while the fast flow malformation occur arterial or can be combined or arterial with any of the above. Pathophysiology of the infantile hemangioma. It is occur in three phases. First is proliferating phase, second is involutioning phase, and third is involuted phase. Proliferating phase. It is a rapid growth from the birth to first 4 weeks, and the most of the growth occur at 6 to 8 months of the life, and at the 6 to 8 months of life, it is usually elevated and become a dome shape and lobulated, maybe flag shaped or tumoral or any combination of this above image showing a dome like elevation, and second image shows plaque like hemangioma. If it is occur in a superficial dermis, then the skin only rise and buccellated appearance is seen with crimson color or dark red in color, and above image is showing. And if it is occur in lower dermis or subcutaneous, it shows bluish hue and slightly raised rather than tumor-like or plaque-like. And during the proliferating phase, vascular endothelial growth factor, it is a best marker to identify the infantile hemangioma, which is highly elevated in urinary and serum. And the beta fibrinogen growth factor and the matrix metalloprotease, it is also a marker which is found highly elevated in urine. Involuting phase, which is up to 5 to 10 years, in which there is crimson color fades to become a dull purplish hue, and the skin gradually pales and patchy gray mantle forms, and it becomes less tense. It is the first sign. This is occurred due to the apoptosis of the endothelial cell, which forming the mass of the hemangioma.
What is that? What actually is apoptosis?
Apoptosis is an inflation of phagocytes of endothelial cell without any inflammatory reaction.
Very good. So the gradually endothelial cells are taken over by mast cell. That's why the word mast cell. That will phagocyte and gradually it involute. Yes.
Involuted phase. There is a regression is completed in 50% of the child by the age of 5 years and in the 70% by the age of 7 years, with continued improvement until the age of 10 to 12 years. About in the 50% of the patient, it become skin become in normal color and rugosity, and about in the 50% there is a residual tumor or loose skin or telangiectasia and scarring may be occur. Below image show A1 image showing the proliferative phase with neovascularization, and the second phase showing fading of this dark red color, and only tumor-like growth is present. And in the third, which is involuted phase, there is only some telangiectasia is seen. Otherwise, no scarring and tumor has been gone. This is another image showing sequence of the infantile hemangioma at the 2-month-old child, showing a hemangioma which is crimson in color, and then after progressively increase at the 3 to 6 months of the life, and color is fading, start fading at 6 months of life, and about at the 26th month it become only tumor-like growth, and all neovascularization has been gone. Another variant of infantile hemangioma is congenital hemangioma, which is maybe started growing in utero and continue throughout the life. There is two type of congenital hemangioma. rapidly involuting congenital hemangioma and non-involuting congenital hemangioma. The rapidly congenital hemangioma is accelerated regression within a few weeks after the birth and complete by the 6 to 14 month of the age, and fades away at the age of 14 months. And then NICH grows proportionately to the child and remain unchanged throughout the life. And this hemangioma is different from infantile hemangioma. There is a hallmark of GLUT1 is negative. There are three different types of congenital hemangioma. The salmon pink patch, which is usually present at midline, on most commonly at forehead and occiput, also called stroke bite. Another is strawberry hemangioma, which is a tumor-like growth due to the endothelial cell proliferation. Can be seen in any part of the body, but most commonly on the head and neck region. It is soft and compressible, and pitting all over the tumor looks like the strawberry. So it's called strawberry angioma. Another is port wine stain or nevus flammus, which is a diffuse dark red stain. And it is not actually true hemangioma, but it is a proliferation of endothelial cell and blood capillaries below the subcutaneous skin dermis layer, and which is most commonly seen or associated with Stuck-Weber syndrome, which is associated with CNS malformation or congenital CNS anomaly, or associated with glaucoma, and port wine stain on the left hemi part of the face.
And angioma in intracerebral, that is also there. In Sturge-Weber, one of the part is intracerebral hemangioma, hemihemangioma on the side of the port wine stain. Okay.
Another is Cutaneous-Visceral Hemangiomatosis. It is a rare condition where the more than 5 cutaneous lesions of visceral hemangioma is present and associated with visceral hemangioma may be seen in the liver, brain, and intestine. Usually occur within the 1 to 2 weeks of the life, which is starting from the face and spread to all over the body, which is a high tendency to bleed, which can lead to congestive cardiac failure or anemia, and may be associated with hepatomegaly, and the marker ES is rise TSH level. Another syndrome is Kasabek-Marriott phenomena, in which hemangioma is very large and life-threatening, but it is a very rare condition. And usually hemangioma more than 5 centimeter due to the rapidly growing endothelial cell, which lead to very formation of the very large hemangioma, and which makes platelet entrapping, which lead to thrombocytopenia, and ultimately patient may goes into DIC, and patient leads to bleeding diastasis. And there is a fibrinolysis product D-dimer, and fibrinogen level will be high. Fibrinogen level will be low, and D-dimer product will be high. PHCES syndrome is a combination of 5 factors, in which P stand for Dandy-Walker or other cystic malformation in the posterior cranial fossa, in which Dandy-Walker there is a malformation of the posterior cerebellum or the vermis, and in H stand for the large plaque-like facial hemangioma, and C for any cardiac defect, and E for any eye anomalies, and the S for sternal cleft. Hemangioma, overall infantile hemangioma, the most common site is head and neck. About 60% of the patient hemangioma start from the head and neck region, which is most common is facial, then eyelid, and then subglottic region. Another as present in decreasing order is trunk, limbs, liver, intestine, lung, and brain. Complication of hemangioma. Complication can occur is most commonly if occur is at the eyelid, can lead to visual problem. If it is occur at subglottic area, can lead to stridor, can be biphasic, if the ulceration most commonly seen in Kasabek-Marriott syndrome, which is ulceration can lead to massive bleeding, and if there is cutaneous manifestation, infection can be spread, and platelet trapping lead to thrombocytopenic hemorrhage. Investigation, the first investigation should be done for hemangioma. If most commonly should be done or useful for when hemangioma is deep dermal or in the subcutaneous plane, which is differentiated from other deep dermal or subcutaneous structure like cyst or any lymph node. And but ultrasound cannot be fully evaluate the magnitude and extent of the hemangioma. But the infantile hemangioma, there is specific characteristic. It is a high vessel density and high peak arterial Doppler shift, which is more sensitive and specific for infantile hemangioma.
हेतल को बोल मैं भी हेतल दीदी को बोला तो हेतल दीदी बोल रही थी पता है.
Another is MRI, which is a gold standard to differentiate between hemangioma and arteriovenous malformation. And last resort is angiogram. Treatment, if there is a only small.
Girish.
Yes.
So you should emphasize the most important investigation is MRI, right?
Yes, sir.
So in all patient it is needed?
No, sir. If there is a
so you should take most of the infantile hemangioma doesn't need any treatment, any investigation or treatment. Agree?
Yes,
so,
sir.
Hemangioma will persist or non-involuting, which does not disappear, those hemangiomas need the treatment. For that, you need to do investigation. But most of the congenital and those in hemangioma disappears. Even in case of congenital hemangioma, when you say Salmon patch and the strawberry angioma, they time of appearance is different and they many times disappear again. But port wine stain never disappear. Do you understand? So in case of port wine stain, you don't need an investigation for a port wine stain, but you need a MRI to rule out associated intracranial anomalies, to rule out Struz-Weber. So if you find a port wine stain in younger patient, it is an investigation not to define the hemangioma, it is to rule out other associated anomalies. So that is the indication. And why you need to differentiate between arteriovenous malformation from hemangioma?
Hemangioma usually benign and disappear after the age of 5 to up to 10 years of age, but the AV malformation remain persistent because in the hemangioma there is not 3-layer wall is formed. Only endothelial will be proliferating, and in AV malformation there will be all 3 layer of vascular most of time is present, can lead to bleeding diastasis and another complications.
Okay, that's right. Second point is that what you have described, are they capillary, arterial or venous hemangioma?
They are, sir, capillary hemangiomas.
So when the veins are having the problem, you call it?
Sorry, sir.
Suppose the vein is the cause, what will you call it? So what is difference between AV malformation and cavernous hemangioma?
In the cavernous hemangioma, there is only endothelial cell layer
of the veins. So basic structure is venous structure, which right. Whereas the AV malformation is, what happens in AV malformation?
In which there is a 3-layer structure is present, adventitia, intermedia and endothelial layer, which is
so what is the point is cavernous hemangioma is usually misnomer. Do you understand?
Yes.
Cavernous hemangioma is very difficult to differentiate from AV malformation. The only point is when it is not pulsatile, right? And bluish in color, you call it cavernous hemangioma. But cavernous hemangioma also sometimes have a feeder. So it is a very low gradient AV malformation, sometimes very difficult to differentiate. But remember, AV malformation is usually associated with abnormal growth of that particular limb or tissue, right? And significantly pulsatile, which will not be there in case of cavernous. But it is very difficult and confusing to differentiate cavernous hemangioma from AV malformation. Same principle goes for arterial. What is arterial hemangioma?
This
Or
hemangioma
other name is, what is other name? Plexiform.
yes.
What is that? It is a true arterial hemangioma, it is called. But ideally speaking, again, same principle. Only point is, here is a predominantly arterial proliferation. So it is again a variant of AV malformation. But when the arterial part is very prominent and it is usually occurring in the scalp. So will you call them hemartoma or no?
Yes, sir.
So are you going to describe them?
Yes, sir. Later on.
So this is the basically, remember, confusing thing. So you should very clarify what you have described just now are predominantly capillary hemangioma. So previously they were only described as a capillary hemangioma, 3 types: salmon patch, strawberry, and port wine. Nowadays there is a part of infantile total hemangioma. Understand this point. The name is only because of the appearance. Otherwise, they are part of congenital or infantile hemangioma. But predominantly, they are capillary hemangioma. Keep this thing in mind. And very rarely, capillary hemangioma requires investigation. So investigation in this case is only mainly for a port wine sometime when it is causing a problem, or non-involuting over once the patient become adult. Okay. Continue.
Yes, sir. Treatment part. Most of the hemangioma resolve by itself at the age of 12 year or in the adolescent age. Does not require any treatment. Reassurance is only. And some hemangioma may need a scheduled follow-up. And some hemangioma which is life-threatening may need pharmacotherapy, chemotherapy, or laser excision or surgery.
Or even cryotherapy.
Cryotherapy.
Cryotherapy is one of the popular treatment in a capillary hemangioma, particularly when they are small and amenable to nitrogen. It is done. That is, the cryotherapy was very popular. Similarly, sclerotherapy, where it is not on a face or an important, sclerotherapy can also be tried. But in capillary hemangioma, it is very rarely tried because most of them disappear on its own. That is the point. Okay.
Pharmacotherapy. When hemangioma is problematic and endangering to the life, pharmacotherapy should be given. First drug of choice is beta blocker. Propranolol is a drug of choice among it. Usually given in the dose of 2 to 3 milligram per kg per day in 2 to 3 divided doses. Duration from 2 to 12 months. Usually effect occur in some hemangioma within 24 hours of starting propranolol due to the contraction of endothelial cells, and it is contraindicated in if patient having a comorbidity like bronchospasm or any cardiac disease or CNS vascular anomalies like suspected in PHCES syndrome. So though in this patient propranolol should not be given. Another is corticosteroid. When propranolol is not working, then triamcinolone, which is intermediate long-acting corticosteroid, should be given intralesionally if the lesion is more or less than 2.5 centimeter of size. And systemic corticosteroid has a role when intralesional is refractory, lesion is refractory to intralesional. Then should be given oral prednisolone 2 to 3 milligram per kg per day in a single morning dose for 4 to 6 weeks. If no effect, then after 6 weeks, steroid should be stopped in step ladder pattern, or in should be should not be taper abruptly, and live action should be contraindicated during the steroid therapy.
Okay.
Another is interferon alpha 2A and 2B, which is indicated only and only if there is steroid chemotherapy is contraindicated, or eye side effect due to the steroid or failure of steroid therapy, because it is a very late action and should not be given along with the steroid, and usually given as a subcutaneous injection, and side effect is neutropenia, and a patient having due to neutropenia, fever, and another opportunistic infection can be occurred. Another syndrome which is include hematoma, which is inherited hematoma polyposis syndrome. These include 4 syndrome: PEUTZ syndrome, familial juvenile polyposis, Cowden disease, and benign RUVALCABA syndrome. So start with PEUTZ syndrome. PEUTZ syndrome, it is a autosomal dominant condition, which is it is a intestinal hematomatous polyps, which is containing extensively smooth muscles. Presentation are usually within the third decade of the life, or first third decade of life, and most common presentation is recurrent colic abdominal pain occurs in most of the patient, within about 50% of patient having colic abdominal pain during its lifetime, and it is due to the obstruction or transient intussusception, and due to the bleeding from the polyps, or due to the intussusception, or due to the ischemia of that part, can lead to the bleeding, and which is usually presented as melena, and less commonly rectal bleeding, and least commonly is hematomasis. It is also associated with protein losing enteropathy, and most common feature or specific feature for PEUTZ syndrome is mucocutaneous macules, which is usually appears at the 5 years of age and fade away at the adolescent age, and the buccal mucosa may be persist through lifetime, which is a specific feature for these macules. And the polyps may be prolapse per rectum in a rare condition if the polyps is reached to a significant size. And patient may be present with gynecomastia of or growth acceleration due to the testicular tumor. This is image showing polyps in the small bowels, and this is a mucocutaneous lesion in the buccal cavity, which is a specific feature and remain persistent throughout the life. If the other macules maybe fade away, but this feature does not go. And another, this small about 3 to 5 mm macules around lips and nose, which is present, and this is MRI showing polyps in the jejunum, which is space occupying and causing obstruction of the small bowel. Laboratory investigation. A complete blood count should be done first, which is suggestive of anemia, microcytic hypochromic due to the chronic blood loss, and fecal local blood will be positive, and CA 125 should be done every year starting at the age of 18 years, and CA 99 should be done every 1 to 2 years starting from the age of 25 years, because the patient having a high risk of colonic malignancy. Imaging modality, these are the investigation can be done in this patient: upper gastrointestinal endoscopy, colonoscopy, if CT scan with oral contrast, capsule
क्या
endoscopy,
पता चलेगा?
and In the MRI enteroclysis, this image showing MRI enteroclysis showing the hematomatous polyps with gadolinium contrast does not uptake in this area, which shows hypointense area obstructing the lumen of the bowel. And this is a dilated portion, proximal dilated portion of the jejunum. Endoscopic ultrasonography can be done if the polyps are present in the jejunum for the biopsy purpose of view. This is the another cancer associated lifetime risk of cancer, which is associated with PEUTZ syndrome. Most common is stomach, then the small intestine, colon, pancreas, lung, breast, and uterus and ovary. According to the this risk, we should advise our patient in the follow-up to routine checkup for these systems. Like surgical option, it is only when then is obstruction or causing hematoma or polyps causing intussusception, and leptotomy with excision of affected part of the bowel can be bowel resection minimized by the intraoperative enteroscopy, and the polypectomy can be the another option is it is present in the proximal jejunum or 2 to 3 polyps are present. WHO diagnostic criteria for the PEUTZ syndrome. If there is a 3 or more histologically confirmed PEUTZ polyp, then it should be PEUTZ syndrome. If any number of the PEUTZ polyps with a family history of PEUTZ syndrome, it's considered to be a PJ syndrome. And if there is a characteristic prominent mucocutaneous pigmentation with family history of PEUTZ syndrome, and there is no evidence of even polyps, it considered to be a PJ syndrome. Or last is any number of the PEUTZ polyps with a characteristic and prominent mucocutaneous lesion considered to be a PJ syndrome.
So this is an important point you should understand. The most important to differentiate PEUTZ from other kind of polyposis is mucocutaneous pigmentation. That is the most significant. Once it is there, it is always for a lifetime, and that is an important differentiating point. So any patient presenting with polyposis, you should always look for a mucocutaneous pigmentation. Continue.
In the follow-up, we should be done annual. If once a patient is diagnosed as a PEUTZ syndrome, once we should do annual complete blood count to see the anemia or acute blood loss or chronic blood loss, or annual physical examination for the breast, abdomen, pelvis, and testes should be done to rule out any malignant changes. Or we should do CA 125 every year starting at the age of 18 years, and CA 99 every 1 to 2 years starting at the age of 25 years of age. And there is every 2 to 3 year interval clean sweep enteroscopy done at the age of 8 to 10 years. Should be, if there is any polyps, should be removed, which decrease the chance of malignancy and repeated surgeries. Usually, because this patient usually come with repeated history of leptotomies due to repeated intussusception and repeated obstructions. Another is familial juvenile polyposis, which is autosomal dominant condition, as like PJ syndrome. Juvenile here refers to only for the histopathology of the polyps. Here, polyps is mostly benign hematoma, which is only considered when the polyps are more than 10. The most common residual of these polyps is colon and rectum, but it can be throughout the GI tract, but may have adenomatous element, and it is associated with congenital anomaly like malrotation of gut, hydrocephalus, cardiac lesion, Meckel's diverticulum, and mesenteric lymphangioma. It is increase the risk of colorectal carcinoma by the 9 to 25%. Though it is benign hematoma, can convert to colorectal carcinoma. It is associated with gastric and duodenal and pancreatic carcinoma. Usual presentation occurs before the patient reaches to age of 20 year of age. Most common presentation is the rectal bleeding due to the most common residing or formation of polyp in the colon, which lead to anemia, chronic abdominal pain, diarrhea, maybe lead to obstruction, or less commonly this rectal these polyps prolapse from the rectum. Macroscopy of this polyp, so there is polyps are usually spherical in shape and often pedunculated and has a smooth and often shiny appearance and can reach from 1 to 2 centimeter to several centimeter in the diameter. And the microscopic view, which shows a mucous filled dilated gland and inflammatory infiltrates, rather than in PJ syndrome where there is a higher amount of smooth muscle cell are present. Screening should be done as a complete blood count, colonoscopy, and upper GI scopy should be start at the age of 15 years. If the patient first degree family member having familial polyposis, juvenile polyposis. If it is negative, then should be repeat screening after 3 years. And if there is a few polyps are there, it should be removed endoscopically. And this patient also should be repeat screening after 3 years. The same is colonoscopy, endoscopy, and complete blood count. If there is polyp burden or increase or dysplastic changes is seen, if hello am I audible?
Yes, audible. Yes, audible.
Yes. Repeat screening should be done in all this patient. Either it is negative or having few polyps. If it is removed endoscopically, after 3 years, if there is no polyp, there is no necessity of colectomy, and should be repeated screening should be done every 3 years. And if there is a polyp burden has increased after removal of polyps or any dysplastic changes seen, then colectomy should be necessary. Surgical option here is total colectomy with ileorectal anastomosis or total proctocolectomy with ileoanal anastomosis. Total proctocolectomy with ileoanal anastomosis is a better option because of juvenile polyps can be occur in the rectum and laterally may convert into malignancy if the rectum is spread.
So this is the difference. If patient is having familial polyposis, investigations of the colonoscopy starts at the age of 10 years. But if it is juvenile polyposis, it starts from at the 15 years. So you should have the report of family member rather than only the history.
Yes, ma'am.
Okay, continue.
Now another syndrome is Cowden disease. It is another autosomal disease, autosomal hematomas disorder, which is due to a PTN gene mutation, which is also called multiple hematoma syndrome. Usual presentation is a patient usually presentation with cutaneous and oral papules goes into skin OPD, and there is a thickening or furrowing of the tongue. It looks like a scrotal tongue, and there is a palmoplantar keratosis or maybe macrocephaly. Patient having adenoid faces, open breathe from open mouth with high hard palate and crowded teeth, and there may be GI anomaly seen in the Cowden disease about 72% of the patients. And here the polyps can be seen from esophagus to anus, most commonly seen in the colon. And here the malignant potential is low as compared to another hematomas disease. Here it is a risk factor for breast cancer in up to the 50% in the female. Thyroid cancer can be occur in 10% of the patient with follicular carcinoma more than papillary carcinoma. Colon cancer, uterine cancer, and urinary bladder or renal cell carcinoma can be occur. Workup should be done in this patient, same like other is complete blood count, thyroid function test, and urine analysis for the urinary system and thyroid malignancy to be ruled out, and skin biopsy should be done to rule out melanoma because of chances of melanoma formation from this papule is more likely. And the imaging study for workup in the patient with Cowden disease should be done.
Remember, the only difference between all these 4 types is genetic difference, right?
Yes.
But what I am interested is what is difference between this polyp, as madam has said, one is a start of colonoscopy. But what is difference between classical adenomatous polyposis, that is familial, and this polyp? Basic difference.
In classical familial adenomatous polyposis, here it is benign, and there is adenomatous proliferation which can lead to 100% convert into the malignancy.
Very good. Excellent. The most important is unless treated, all adenomatous polyposis patient will sooner or later develop malignancy because it is a adenomatous transformation. So will you call that as a hematoma?
No, sir.
What is that? So that is, remember that difference you should understand. That is not hematoma. This we are discussing hematoma, that is actually normal tissue deviation. But they rarely, though here you have seen the percentage is very high, it is not that high. Whether it is a PEUTZ or any other associated, the actual malignancy is not very high because they are basically hematoma, where the chances of conversion to malignancy is there, but it is not very much increased compared to normal person. But in adenomatous classical polyposis, it is almost 100%. Only matter is years.
Another imaging study are annual mammography to rule out or prophylactic for breast cancer should be started 30 years or 5 years before the earliest breast cancer can be if detected in the family. Should be done MRI brain, should be done angioscopy and colonoscopy, and CT IVP also recommended in this patient. Treatment, therefore the cutaneous manifestation, systemic acid resin should be given, but recurrence is always a rule if we stop the acid resin, and the surgical excision of the polyp should be done, and prophylactic mastectomy has also been indicated in Cowden disease. Another hematomas disease is Banana RUVALCABA Rayleigh syndrome. It is usually combination of Banana, RUVALCABA, and Rayleigh syndrome, which is autosomal dominant, and due to the P10 mutation, incidence of this disease is 1 in 2 lakhs, and the manifestation occur is macrocephaly, intestinal polyposis. Up to 45% of the patient occur in distal ileum and colon, and pigmented macule over the penis, which is a specific feature seen in this syndrome. And another hematomas lesion can be seen as a lipomatosis, hemangiomas, patient with high birth weight and proximal myopathy and hyper extension at the joint, and as well as developmental delay and intellectual deficiency can be seen. And no such criteria exists for BRSS syndrome, but the syndrome is suspected in the patient if the presence of first 3 characteristics of macrocephaly, intestinal polyposis, and pigmented macule of over the penis. And thyroid pathology is finding can be benign or malignant, or there is a lifetime GI malignancy risk, but it is unknown. Sir, Chintan will be doing from Neurofibroma, sir. Hello? Am I audible, sir?
Yes, audible. Continue.
Ma'am, from now onward, from Neurofibroma, Chintal will be carry on, ma'am, from next lecture.
Okay. So only one thing, I think you were not present last time. See, we covered up all these things also last time in polyposis also,
Yes, ma'am.
right? So you remember the difference between this Cowden syndrome, familial polyposis, and juvenile polyposis. These three things should be differentiated. And its presentation is also a little bit different. So you have to remember all these things, right?
Yes, ma'am.
Okay.
Thank you, ma'am.
So we'll continue next time.
Yes, ma'am.